Good morning and welcome. This is today's edition of the Psychiatry Grand Rounds for the Department of Psychiatry on October 6, 2022. I'm Robert Claudel, Residency Program Director. It's my pleasure to introduce our speaker today. This is Dr. Elizabeth Wassenaar. She's the Regional Medical Director for Mountain and West Regions. She oversees clinical care at the Eating Recovery Center and Pathlight Behavioral Health. Prior to that role, Dr. Wassenaar was the Medical Director at Williams House Adolescent Residential Facility at Linder Center of Hope outside of Cincinnati, Ohio, just down the road from us, and on the faculty at the University of Cincinnati and Cincinnati Children's Hospital. She's board certified in adult psychiatry, child and adolescent psychiatry, and obesity medicine. She's also trained in pediatric medicine. Dr. Wassenaar has completed advanced psychotherapy training in child and adolescent psychodynamic psychotherapy through the Cincinnati Psychoanalytic Institute, also family-based therapy training for eating disorders through the University of California, San Diego Eating Disorders Treatment and Research Center, as well as ketamine and MDMA-assisted psychotherapy. That would be an interesting grand rounds in and of itself. Dr. Wassenaar is a clinical instructor at the University of Colorado Anschutz Medical Campus and is an avid researcher and academic writer. Outside of work, she enjoys spending time with her partner and their very energetic dogs. Thank you for coming today, and I look forward to hearing what you have to say.
Thank you so much. Thank you for having me. Let me share my screen. Right. There we go. Okay. You should be seeing just the presentation view. Is that correct?
Yes.
Excellent. Okay, thank you so much for having me. I did train just up the road in Cincinnati in the triple board program there. I think when you train in pediatrics and psychiatry, the people with eating disorders naturally find you because they know that you are maybe not quite as scared as some of the things that patients with eating disorders can bring along. And I found that the thing that people are most fearful of when they're trying to think about treating eating disorders are the medical complications. What happens if someone is too medically unstable for me to be able to help them? And so I wanted to spend today some time going through the medical complications of disordered eating and hopefully provide you some education and reassurance that this is stuff that you can handle, and also to know what you might need more help with and how to get the help for your patients so that we can rely on all of us to help take care of eating disorders. I'm sure you're aware, have seen in the news that we're just seeing increasing numbers of eating disorders, especially in child and adolescent patients. So something that you haven't seen yet, you will. It's just a part of doing this work, and having the resources you need, I think, is so crucial. I was asked to put this slide up, so I said I needed to leave it up for a few seconds. So this is the slide that you need to get your CME, I believe. All right, so today we're going to walk through some common medical complications of disordered eating patterns, discuss reversible and non-reversible medical concerns for patients with eating disorders, and describe treatment planning for various medical issues related to disordered eating patterns. So we know eating disorders are complex biopsychosocial diseases. They are neurobiologically based, socially influenced, and culturally informed disorders that are about food but are not about food. And eating disordered behaviors often serve as an expression of psychological states and needs, and then also become their own psychological state and need in the state of malnutrition and or other medical consequence because of the disordered eating pattern. Eating disorders do not discriminate. They affect individuals of all ages, genders, ethnicities, socioeconomic backgrounds, and in a wide variety of body sizes and shapes. I think that one of the things that we are really passionate about is making sure that we are serving all bodies with eating disorders in our eating disorder treatment facilities. Many times people in non-traditional sizes of bodies have been marginalized within eating disorder treatment facilities. So that's something to keep your mind open to, that any patient you talk to in any body can have an eating disorder. Weight is not the only clinical marker of an eating disorder. People who are at all weights can have eating disorders, and individuals at any weight can be malnourished or engaging in unhealthy eating and weight control practices. Individuals with eating disorders may not recognize the seriousness of their illness and or may be ambivalent about changing their eating or other behaviors. Eating disorders are very egocentric oftentimes, and also a part of the disorder itself is lack of recognition of the seriousness of it. So those conversations can be difficult. Arming yourself with data is your best weapon. All instances of precipitous weight loss or gain in otherwise healthy individuals should be investigated for the possibility of an eating disorder. Rapid weight fluctuations are potential markers for eating disorders. In child and adolescent patients, we're very sensitive to failures to meet expected weight or height markers, or delayed or interrupted pubertal development, and should be considered a red flag for eating disorders. Eating disorders have a high rate of short-term and long-term medical complications, and very often we see a very long delay in appropriate recognition and treatment of eating disorders for a lot of reasons. Weight loss is oftentimes celebrated in our culture, and so very often it's something that flies under the radar in adolescent patients. When anorexia nervosa persists into adulthood, the cost for treatment and quality of life indicators actually rival chronic schizophrenia. So it is a very costly and disease, both financially and socially. And eating disorders have a high rate of mortality. So anorexia nervosa was our most mortal of the mental illnesses. It has now been surpassed by opiate use disorder, unfortunately. However, we still have a very high rate of death in patients, especially with anorexia, and a very high rate of suicide completion. This is just going through the criteria, and I'm wondering, oh shoot, okay, sorry, there's some animation here that I didn't mean to leave in, but here we are. So anorexia is the disorder that's characterized by restriction of energy intake, leading to body weight below target body weight. At this moment, we still separate out people who have sort of a objective low body weight as having typical anorexia, and people who have a body weight that's lower than where their body wants to be, but not below a sort of concrete number as having atypical anorexia. However, we see really that these patients present very, very similarly from a mental distress perspective, as well as a medical complications perspective. And in fact, the highest risk factor for patients with restrictive eating disorders is really the rapidity of their weight loss. So regardless of where they started or where they end up, if they lose weight very, very quickly, that puts them at a great cardiovascular risk. So that's the marker that I'm usually looking for when I'm evaluating people for level of care, is how much weight have they lost and how quickly. Anorexia nervosa, sorry, just to go back, can present with just restricting, but it can also present with binging and purging behaviors. But then we also have bulimia nervosa, which presents with primary use of eating a larger quantity of food and then engaging in purging behaviors that can be vomiting, diuretics, laxatives, or exercise. Bulimia nervosa is somewhat of a different entity from anorexia nervosa. When we meet these patients, people with bulimia nervosa tend to struggle more with impulse control concerns and compulsive behavioral uses, including addictive disorders. So that can present a different level of complication when we have somebody who's using an addictive substance or needs to go through detox or withdrawal when they are getting help for their eating disorder. And then we also are tending to see more laboratory and EKG changes in patients who have bulimia nervosa because of the nature of the purging behaviors, and we'll walk through some of those. Binge eating disorder had been long under-recognized as really the most common eating disorder. It is more common than anorexia nervosa and bulimia nervosa combined. And I think we are entering a time where people are really being able to recognize and name this. However, it still remains a disorder that has limited access to care. Insurance companies don't necessarily do a great job of recognizing the need for higher levels of care for binge eating disorder because the acute medical complications are not as pronounced as our other eating disorders. And I think that it's still pretty widely under-recognized in the larger medical areas. People who are normal weighted are very, very often missed with binge eating disorder. So this is another one that is, it's very difficult for people to seek help for and be recognized if they don't sort of meet the sort of stereotyped idea of what somebody with a certain type of eating disorder looks like. So 30% of people with binge eating disorder are not overweight or obese. So that's an important part of the population to ask about. And then everywhere, we're seeing more and more people who actually have had bariatric surgery. Binge eating disorder is not well recognized. Well, that's not true. It's not well, it's not necessarily super well identified and called out in the bariatric surgery communities for a number of reasons. I think that eating disorders are a difficult thing for the wider medical community to identify and know what to do with. There is some conflicting literature that indicates that right after bariatric surgery, people with binge eating disorder do somewhat better. However, the long-term data shows that they don't actually do better in terms of maintaining their weight loss, but also in terms of their disordered eating patterns and the mental distress associated with the eating disorder. So after bariatric surgery, we will often see that people who have binge eating disorder will resume disordered eating behaviors. Because of the surgical pouch, they may not be able to eat in the way that they could before. And so we'll see them eat, really have more loss of control eating that's contraindicated based on size, content, or physical capacity. And that can look like grazing, plugging, and or dumping. Eating a lot through the day, eating food too quickly that gets stuck and causes purging, or eating food that's contraindicated and pulls fluid into that small intestine, which can actually be very dangerous in terms of fluid shifts and can cause syncope. And then we do see a different group of people who have a post-surgical eating avoidance disorder, which looks much more like traditional anorexia nervosa. So these are people who have an intense fear of regaining weight, very rigid food choices, and cognitive distortions related to their food and eating patterns, as well as phobic avoidance of food, and oftentimes distortions of their actual body size and shape. And those people do make their way into eating disorder treatment. Although, unfortunately, we are now seeing that a number of them, especially the top group of people who resume binge eating disorder, are making their way back to bariatric surgeons and getting surgical revisions. About 50% of bariatric surgeries now are actually surgical revisions for people that failed bariatric surgery. So that's where we are at the moment. Avoidant restrictive food intake disorder, ARFID, used to be known more as feeding and eating disorder of infancy and childhood. And this is more of a phobic avoidance of food for a variety of reasons. It could be neophobia, so patients that are very, very fearful of new foods or new food experiences, patients who have co-occurring OCD or autism spectrum disorder, or patients who have other sorts of phobic avoidances like emetophobia or fear of choking. That actually leads them to having malnutrition based on their food intake. They do not actually experience disturbance in the way that they experience their body size or shape, or value themselves based on their body size and shape, but just the experience of being malnourished can actually further influence their food rigidity. And then for the other specified feeding and eating disorders, we talked about atypical anorexia already. I always like to mention night eating syndrome because I think it's an important one for us to know as psychiatrists. Patients who have night eating syndrome oftentimes have binge eating disorder also, but not always. Night eating syndrome is thought to be a unique disorder based on circadian rhythm abnormalities. So you want to be screening your patients with ADHD and other sort of disorders that can impact their circadian rhythm and their sleep-wake cycles, people who have shift work, things like that. So people who have night eating syndrome are eating the majority of their calories at their night meal and after their night meal. They typically are not hungry or actually have really significant food avoidance in the morning. So I have patients who, when they try to eat breakfast, they vomit because their body does not want food. So it's a process of getting them to be able to have a more normal eating pattern. They often report an inability to go to sleep without eating, oftentimes eating until they are uncomfortably full. They have evening dysphoria, worsening mood and irritability through the evenings, and they do remember these eating events. So we know that some of the medications that we prescribe from time to time can cause amnestic events overnight, especially sleeping medications. This is not that. That's a different parasomnia. So this is a specific circadian rhythm disorder related to their eating patterns. And in fact, it responds very, very well to light therapy. So that is my first intervention is actually normalize the eating pattern, getting them eating breakfast and doing bright light therapy. And oftentimes that actually resets things, and that's all they need, although some do need support for co-occurring disorders. And then subclinical sort of disorders that fall under this umbrella term as well. So eating disorders can occur at any time, but we do typically see ARFID in younger kids, anorexia in early adolescence, bulimia in mid-adolescence, and binge eating disorder in later adolescence in women, and actually it's identified most in middle-aged men. Now that's when it's being identified. I think that the data is starting to separate out as we have more good data, especially on binge eating disorder. And we do see the onset of these sort of disordered eating patterns oftentimes in childhood across the board. So we know that medical concerns can affect every part of the body. And so, you know, when you have somebody who has any physical complaint, of course, you want to be screening for all of the other things that we always screen for as psychiatrists and think about with the thyroid and all of that kind of stuff. But this is just really something that's important to keep in mind. And psychiatric comorbidities really are the rule, not the exception. So patients who have eating disorders oftentimes are really struggling socially and emotionally. So they're withdrawing from things that are important to them. We oftentimes associate, especially anorexia nervosa, with high achieving perfectionists. And that is true. We do see that sort of idea bear out when we look at the data. And so when you have somebody who's a high achieving perfectionist and they choose to go to the gym versus finish their homework, or they are hurting themselves so that they are not able to perform at the top of their sort of whatever thing, be it a sport or school, that can give you sort of an indication that the eating disorder is actually now the thing that has taken priority in their life. And that can also be helpful for parents, you know, to help them realize that they've actually crossed the threshold. They're no longer making choices in service of doing well at something. They're making choices in service of serving their eating disorder, which is trying to get them to lose enough weight or build enough muscle or engage in enough compulsive behavior to make things feel better, and it will never be enough. We often also see them have a lot of irritability, and even sometimes aggression towards their parents or friends, which is really out of character for these patients. They will have previously been described as, perfect, which has its own barrier, own sort of baggage there. But, they are the kind of people who are really good rule followers. They know what people need from them. They always try to live up to those expectations. And then all of a sudden you have somebody that's throwing a plate at their mother, and that is very out of character. I want to make sure that beyond just this presentation, you have some other resources. So this purple brochure is available online. It's PDF. You can download it. It has a great resource for medical management of patients with eating disorders. And it was actually put together by a parent initially, and then backed up by medical experts. It has important facts, presenting signs and symptoms, and I think is a really great tool for you to have on your shelf, but also to have as a resource when you are consulting or working with other professionals and especially other physicians on, like, what should we do with this patient? So for those of you on CL service, this is a great resource to have at your disposal, so that you can drop that recommendation in the notes on what they might be able to access to support the patients. And it's endorsed by medical societies across the internationally. Okay, so the key things that we're going to talk about today, this is related to malnutrition. So acute malnutrition is an urgent medical issue. All eating disorders are serious mental illnesses with significant life-threatening medical and psychiatric morbidity and mortality, regardless of weight. Anorexia nervosa has a high mortality rate, which we've talked about already. And early recognition and timely intervention based on developmentally appropriate multidisciplinary teams is the best standard of care. And almost all patients with eating disorder have some level of ambivalence about recovery. So the essential medical workup. So what is it? What are the things that you want to gather? What do you want to sort of put together in order to get started with this? So, the cornerstone of the work we do is a good history and physical, and that can be either done by you or in collaboration with primary care colleagues, internal medicine or family practice colleagues. Obtaining longitudinal growth data is incredibly important to be able to see what were the projected growth targets, and have they met them, or how much are they missing them by. That can also be a very crucial step to figuring out like how far off they are from their growth targets and what level of care they might need. Labs, CBCs, electrolytes, and renal tests, liver function tests, glucose, urinalysis, thyroid tests, and sometimes serum salivary amylase can be helpful if you suspect purging. It's not something that I would use as a rule out. Like if it's normal, I wouldn't say, well, I guess you're not purging, but it can help you to rule it in. So it can be something that can be a helpful thing, a helpful tool, especially if there's denial or ambivalence on either the patient or if you have parents involved, parents' part to recognize the eating disorder behavior. These are some additional things that you might get for specific patients based on specific situations. So DEXA scan looking at bone health is something that you might gather if you have concerns that they've been engaging in disordered eating for a period of time, or they've stopped menstruating and you're wanting to see what their bone density is. GI workup can be really helpful for a couple of reasons, to sort of fact check the patient. Like they can say, you know, I'm completely full of stool, and you can see if that's true or not. They might say something like, I'm definitely not taking laxatives. I must have some sort of GI bug or something. And then there are some things that you can use for that as well. So there's some reasonable reasons to get this, but it's not necessarily necessary for every patient, just based on symptoms or presentation. So how do we figure this stuff out? So my advice is to ask directly and name behaviors. So we know eating disorders live in secrecy and shame. So if we don't name it, oftentimes patients won't either. So I think it's important to talk about this with the same sort of objectivity that we talk about safety concerns, we talk about suicidality, we talk about a lot of things that are really hard to say out loud. But when we approach it with an attitude of objectivity and compassion, I think it allows our patients to be able to begin to recognize that this is something we need to bring light to and we need to talk about. And I think reiterating that you want to know about this because you care about them and the things that they're engaging in may hurt them. So food restriction, are they restricting overall? Are they restricting specific items? Loss of control eating or feeling like you eat more than you meant to can be a way to describe binging. We have a lot of patients who have eating disorders who intentionally either restrict or overload on fluids based on various compulsive sort of experiences. Purging, which can look like making yourself vomit. It can look like using diuretics or laxatives. It can sometimes look like using digital stimulation to make yourself stool. So there's a lot of different ways purging can look. Excess exercise, which I typically ask, like, have you exercised past the point of hurting yourself or past the point of people saying that it was dangerous for you, and or is it interfering with your life? So are you going to the gym instead of going to a birthday party, things like that. Rumination, which is where people bring food back up, they chew it again, and then they swallow it. This is a very, very difficult behavior for patients to admit to. It's very, very socially impactful, as you can imagine. It is not a pleasant behavior. It's very compulsive and oftentimes almost habitual for some patients who struggle with this. So naming that one is, I think, really important. Chewing and spitting is something a lot of people with eating disorders don't even realize is a part of their eating disorder. They just think it's a clever strategy to get the taste of something they want, but not get the calories. And so naming that as a disordered eating behavior, I think is a really important thing. Overuse of caffeine or other stimulants and misuse of prescription medications. When someone is just restricting, their labs may be normal. One of our founders, Phil Naylor, who wrote a book on also managing the medical complications of eating disorders, which is another great resource, has said people with anorexia who are just restricting will go to their grave with normal labs, and that's true. So normal labs, labs are very important. It's very important to have baseline data, but normal labs do not necessarily reassure me that someone is fine, especially not in a lower level of care, and especially not if they're still restricting. So we will see that labs will become abnormal once we encourage them to start eating, and that's when things really get dangerous. And then food has a lot of the fluids that our bodies depend on. So when people aren't eating, they're often restricting fluids just by the nature of not having those fluids in their food. The cardiac exam, can be positive for just low heart rate or low blood pressure, which can result in cold extremities, difficulty with perfusion, and dizziness or fainting. And in severe caloric restriction, the heart will lose muscle mass, which impacts blood flow and heart rhythm. And this is one of the things that does actually compel us to look for a higher level of medical care, because obviously if the heart rate is low when they're up and walking around, when they're sleeping, it's very low. And that is a point when things can get very, very dangerous. So I wanted to bring your attention to and or remind you about the where we started to gather a lot of data about what calorie restriction does to the body with the Minnesota semi-starvation study. So this was back in World War II. These were conscientious objectors to the war. This was something that we would not likely be able to get done today, but we have the data to be able to analyze. So they basically wanted to see what would happen if they took normal healthy volunteers and they put them on a significantly caloric restricted diet. And this has actually informed a lot of how we understand what calorie restriction does to all of us. And also then to like tease that out from how is that different from patients with eating disorders? So what parts are related to malnutrition and what parts are related to the mental illness of an eating disorder? So they found that anybody, and actually they picked the most healthy men. So they picked these very, very healthy, emotionally stable men to engage in the study. And they found when they put them into prolonged periods of semi-starvation, they had depression, irritability, distress, anxiety, apathy, and they became obsessive. They also experienced self-harm, preoccupation with food hoarding, binge eating, social withdrawal, decreased strength and stamina, decreased body temperature, decreased heart rate, and impaired hormones and sex drive. Oh, and all symptoms that could be observed in patients with eating disorders. So we know that from that data that low body weight and or malnutrition, excessive dieting and restriction can result in what looks like eating disorder behavior and thinking. And what that lets us know about is that we have to treat the weight and the malnutrition in order to impact the emotional distress and the underlying mental illness components of the eating disorder. So it is almost impossible, I'll never say never, but it is very, very, very difficult to treat an eating disorder adequately unless you are first and concurrently addressing nutrition. And I would probably bet, if I had money to put down on it, that those of you who have treated people with eating disorders at some point, one of them or many of them tried to say, can we do the therapy work first and then I'll get to the eating stuff later? And that's very common because the eating stuff is the hardest part. It's painful and their brain is saying it's dangerous for them. And my answer to that time after time after time is no, we cannot. We cannot do the therapy part first and put the nutrition off for later. We have to do both at the same time. And if we have to prioritize, then we have to prioritize nutrition over therapy. That's necessary because your brain and body will not get better if we don't address the malnutrition. All right. With caloric restriction, we can often see that liver labs may be abnormal due to starvation and or refeeding. This is something that we monitor and watch when we're helping people to become nutritionally restored. If their liver labs really spike, then we just pull back on the number of calories that we're giving them or the amount of fat in their meal plan. And then we also are watching really closely for other medications that can elevate their liver labs. So not uncommonly, patients who are in eating disorder treatment, especially at the higher levels of care, are also on an antipsychotic. And that is because those medications are really, really helpful for the agitation and the distress and the disordered thinking that goes along with eating disorders. We do not typically see antipsychotics cause like hyperphagia the way that we would see in other patients that might be on antipsychotics. So we don't see patients become excessively food seeking on antipsychotics. It just helps them calm down and eat more normally. But we do watch their liver labs closely because occasionally we see elevated liver labs, and in combination with the antipsychotics, that can be something that we don't want to stress their body out more than we need to. Abnormal thyroid tests are very, very common in starvation. So we call this sick euthyroid syndrome. This happens to everyone, not just patients with eating disorder. It happens to patients with cancer and all sorts of other chronic illnesses that have malnutrition as part of it. And treatment is nutritional rehab. We do not supplement abnormal thyroid tests in early eating disorder treatment. In patients with caloric restriction, we see a lot of physical symptoms like emaciation, dry skin, brittle hair and scalp, and hair loss, physical restlessness and hyperactivity, pressure sores. Their skin can be somewhat yellowed, and then they can have this lanugo, which is that picture on the upper right corner with the face with a little bit of fine downy hair that the body will grow to try to keep itself warm. And then if a patient loses enough muscle mass from their heart, they may also have a mitral valve prolapse, and that can be dangerous as they're refeeding. So if you are noticing, or if someone has noticed a heart murmur, it's important to get cardiology involved. GI symptoms are universal in eating disorder patients, and this is severely underweight patients, but I would say also very much in patients who engage in purging behaviors. And also the treatment for GI symptoms is regular nutrition. We see slowed digestion in almost all of our patients. It commonly manifests with bloating and pain. Takes weeks to get better, not days. And we try to supplement with Boost and low fiber foods to try to help them. It also is why we feed them so often. So in our treatment facility, we feed people 6 times a day, and then sometimes they have an overnight feed on top of that. And that's because we know that their GI system is under conditioned and they need to take this flow to get going again. So that's sort of the standard of care for what we're doing. And it is very hard for them to eat that many times a day, but it does make it more comfortable. Reflux is also almost universal based on just the fact that they haven't been using their GI system oftentimes very much, or if they are using it, they might be engaging in purging, which worsens GERD. Sometimes our patients tell us, well, I can't swallow. I can't eat as much. You're telling me I need to eat because I can't swallow. Something wrong with my esophagus. That has been really looked at consistently over the years. There have never been consistent difficulties with swallowing in patients with anorexia nervosa. It's also an important point for patients who have ARFID and are avoiding food because they're fearful of choking. That they're, people who are malnourished are typically found to have no consistent difficulties with swallowing. Superior mesenteric artery syndrome, SMA, is a consequence of being very underweight. And it is when the small intestine compresses, the aorta, the blood flow to the small intestine gets compressed. It is actually very painful, and it is the result of a loss of very significant visceral fat mass. It does resolve with weight restoration, and that is the #1 treatment for that. But for patients who have SMA, we very frequently are using a slow boost or like slow supplement continuous feed through an NG tube to try to not overstress their cardiovascular needs to their intestines. Gallstones can happen as a result of rapid weight loss or the use of specific diets, which we'll talk about in a moment, and are painful and need to be addressed. Constipation is absolutely almost universal. I don't know that I've taken care of a patient with an eating disorder who did not complain of constipation at some point. And that can be due to underuse of the GI tract overall, overuse or dependence on laxatives, and or what sort of foods that they're eating. It's important to sort of remind people about what our normal expected stooling patterns are. It's actually within the realm of normal to not stool every day. Our patients are shocked by that. And so it just sort of helping them to normalize, like, this is where their body's at, and also keep an eye on it. If they are very, very underweight and have very underfunctioning GI tracts and or we're very, very dependent on laxatives, they can actually get backed up. And sometimes they do need a clean out, and you do need to use that abdominal x-ray to make sure that they don't have an overwhelming stool load. This is another place where it's important to be thoughtful about your medication. So we know that if we use a whole bunch of antipsychotics and antihistamines, and they're on, fluid restrictions because they overuse fluids and their sodium's low or something like that, like all of those things together can absolutely create a dangerous situation with constipation. So it is something that we do keep a close eye on, and we do occasionally send people out for an actual clean out and or using things like, TID, Miralax, and enemas and things like that. When people are restricting calories, we very frequently see amenorrhea or loss of menstruation. Primary amenorrhea is obviously when people don't have menarche because they had the onset of their eating disorder prior to onset of menarche, and then secondary amenorrhea is when their menarche stopped and may actually occur before they have significant weight loss, which is an interesting way that the brain and the body are linked in ways that we actually don't totally understand quite yet. And then fertility issues are a large concern for people with eating disorders. So if you have a woman in your clinic who's struggling with fertility, and so this is on this slide from caloric restriction, but you'll see it later on our binge eating disorder slide and binging disorder. So patients who have both caloric restriction and binging actually struggle with fertility and with having children. I'm going to call out bone health for one very important reason. So this is one of the only non-reversible consequences of an eating disorder, of a malnutrition eating disorder. So we know that especially women lay down a lot of their bone density and strength through their adolescence. And if they're engaging in significant malnutrition practices, then they actually will not be able to catch up on that. It's like, I liken it to a retirement account. So you can put more money in later, but it will never have the same weight as the money you put in earlier, which is, very depressing when you're in medicine, when you spend your entire 20s, being in school and accruing debt. But I think that it is a good and apt sort of way to help people understand the importance of why we are so, or we have so much urgency around getting people back on track from a nutrition standpoint as young as possible. Let's see. Okay, so this is just more about bone health. We do prescribe calcium and vitamin D to the majority of our patients, and sometimes we use bisphosphonates if they have really significant osteoporosis. Birth control pills, very, very important piece. This is a piece of take-home information. So there used to be an idea that if we restarted menstruation, then we would restore bone health and everything would be just fine. And so a whole bunch of people were put on birth control pills in adolescence who had eating disorders in order to sort of compel their bodies into menstruation. And we know now that that didn't actually protect their bone health. So if they need birth control pills for contraceptive use, please help them get onto those. That's very, very important, especially if they're recovering from an eating disorder. But if they're using it to try to protect their bone health, that won't work. The thing that people are often very afraid of is refeeding syndrome. So we know that when somebody has not been eating well and then they start to eat more, that they can have significant shifts in their fluid and electrolytes, and that can be serious and even deadly. So the risk is associated with the degree and pace of weight loss. So remember I said earlier that one of my key take-home points is how much weight have they lost and how fast, because that helps me know how much support are they going to need in this early part of their treatment when they have the highest risk for refeeding. The greatest risk is in the first 2 weeks, and so the best recommendation is frequent labs. We do labs daily when people are admitted to our care, and I don't think it's unreasonable if you're following someone in a lower level of care or outpatient to ask them to get labs done frequently. If someone needs more than once a day labs because their electrolytes are so unstable, then I would very strongly recommend they be in a medical bed. Fluid restriction can result in markedly decreased ability to tolerate the fluid intake. So when patients come in and they've been restricting fluids and then we ask them to, start to take in fluids, we can see hyponatremia. Their kidneys need some time to adjust. And so we treat dehydration very conservatively to reduce the risk of CPM. And this is just a graphic of why refeeding syndrome happens. I think the thing to know about refeeding syndrome is, okay, so as we refeed people, we shift them from a catabolic to an anabolic state, and their phosphorus is the thing that moves, and that's the thing that we worry about. So that's the thing that we supplement. So the thing about refeeding syndrome is just to know, what am I monitoring for and how do I supplement for it? And if you have those two pieces of information, then you have a lot of power to help them stay safe. All right, let's see. The other things that happen in early treatment for people who are severely malnourished is that we oftentimes increase circulatory blood volume because all of a sudden they're not quite so dehydrated. And when they have a very, very compromised cardiovascular system or their heart has lost a lot of muscle, then that actually can result in heart failure. And that's the kind of patient that you want to have in a medical bed and or a medical unit that's devoted to treating eating disorder patients, like acute at Denver Health, which is in Denver. I am looking at the time and I'm recognizing that we have, I think, just until 12:30, and I want to be able to get through a few more things. So I'm going to go through a few things more quickly and make sure that I have a chance to talk through a few more things. So purging is the other big behavior that has a lot of acute medical complications that I want to let you know about and talk through. This is the place where we see more electrolyte abnormalities, as well as significant dehydration. And when a patient with a purging disorder presents to emergency room, they often look pretty dehydrated, their electrolytes look bad. And so emergency physicians will load them up with fluids because that's what we do when people are dehydrated. But for patients with eating disorders and their kidneys are very deconditioned, that can lead to significant edema and volume overload. And so what we recommend is actually slow fluid replacement, trying to use their GI tract when we can, and trying to use electrolyte containing fluids like broth or Gatorade. So we frequently see low potassium in all types of purging disorders, vomiting, laxatives, diuretics. And when you have significant hypokalemia in an otherwise healthy appearing young person, you want to be very suspicious for a purging disorder. When the calcium is low and the bicarb is high, you're thinking vomiting. So that's a little nugget to tuck away in your memory as something to watch out for. This hypokalemia can predispose patients to palpitations and cardiac arrhythmias, and low potassium in young females is associated with increased mortality. The efficacy of potassium repletion is negated unless volume is also restored. And also when we restore volume too fast, it causes edema. So this is a delicate balancing act. These patients, I actually do sort of more preferentially try to put at a higher level of care because of the number of things we need to monitor as we're helping them to get to interrupt the behaviors and get some restoration. When people are engaging in vomiting, they oftentimes have dental concerns, and obviously because the gastric acid is impacting their enamel. And swelling of the parotid glands and gingivitis and throat soreness, and painful swallowing and all of the things that go along when you engage in excessive vomiting. The Russell sign is this is an old sign, but still holds up. If they're using their hands to help themselves purge, you can sometimes notice that on their knuckles, they'll have some abrasions. And or if they're using an object to help themselves purge, we do sometimes see that they accidentally swallow it. So I've seen people with toothbrushes in their esophagus, or forks, which is obviously very dangerous. It's a medical emergency. And if they have ever spitting up or vomiting blood, that is another reason they should probably go to the emergency room pretty quickly, make sure that they are not having something more serious happening. Excess use of laxatives may damage the colonic nerves that stimulate normal stooling. And so when people are using stimulant laxatives, our recommendation is to cold stop. So there is no protocol that indicates that tapering off stimulant laxatives is better or easier. We need your body to be able to start to use its nerves the way that's supposed to be used. So we strongly suggest that people stop their stimulant laxatives cold turkey, and that we use non-stimulant laxatives like Miralax, regular nutrition, and enemas if we need to help them be able to stool more normally and their nerves to regenerate and get stronger again. When people are using digital stimulation, that can result in damage to the rectal muscles and also concern about hygiene. It's a very difficult behavior for patients to talk about, but we do see it with some regularity in people who are really sick and at high levels of care. So it's a good one to just know that it happens, and again, create a space where people can talk about the things that are hard to talk about. When people have an excess use of diuretics and then they stop abruptly, it can cause rebound water retention and edema. Patients may feel like they're gaining a lot of weight, and that can actually lead them to sort of like go right back to their eating disorder. And so at the higher levels of care, and actually you can do this as well, when someone has that experience, it's called Pseudobarter syndrome. So they when they have severe volume depletion, then their kidneys upregulate the adrenal aldosterone to release to help reabsorb sodium and water and prevent fainting. When we stop it, then the kidneys are still doing what they were doing to help save you. And so now you're carrying too much water and too much sodium. And so we use aldosterone, spironolactone to help patients with that process and help their kidneys get normalized, because that actually does take weeks, and it is a reason that people fail out of eating disorder treatment. They'll leave if they think that they've gained too much weight. It can also actually be dangerous. I've seen people have like 9 pounds of weight gain in 2 days, and it's just water retention. So that is painful and dangerous. So it's something that we want to keep a close eye on. And then sometimes people are using diet pills, which we know we don't know what's in them. It could be anything. It could be nothing, and it could be illegal substances. So the medical complications will vary based on what they've actually put into their body. Rumination, we've talked about, that's where they bring the food back up and then re-swallow it. It can be associated with reflux, and is very difficult for patients to talk about. Same dental and oral concerns as the vomiting, with the gastric acid hitting the enamel of the teeth, and very, very socially impactful. Chewing and spitting results in primarily caloric restriction, but can also result in dehydration, and excessive exercise. So this is one that patients often try to say, well, walking is really good for your bones. It helps them get stronger, but not when you're malnourished and you already have a lot of bone weakness and loss. It actually makes things a lot worse. So our recommendation for patients who are severely ill from their eating disorders and are coming into treatment is to stop exercising entirely and allow their body to regain strength. And then we make individual plans for each patient based on what exercise is going to look like for them going forward. When patients can excessively intake fluids, it can be due to compulsive behaviors or like psychogenic polydipsia, which can be seen in patients with eating disorders. It can also be used to help them not feel so hungry. It can lead to very dangerous low sodium levels, and that is something that we want to correct slowly, because the kidneys will have probably upregulated to try to normalize things. But this can be something that can be very difficult to interrupt. And so sometimes we have to put people on one-to-one everything, everywhere that the water is running, in the spa, in the shower, in the toilet, to make sure that they're not drinking excessively. And then some patients feel a compulsive need to be dry or avoid taking in fluids, and it can actually put themselves into kidney failure. And so this is another sort of behavior that we want to watch really closely on. The kidneys will have downregulated to try to do what they can. And so if they are repleted too quickly, that can result in really significant electrolyte disturbances and increase the risk of complications. So we talked a bit about binging and how binging is not always associated with being in a larger body. Obesity is a complicated, totally separate talk that I'd love to come back and talk to you about. But so I use the word obesity to refer to an endocrine disease of dysfunctional adipocytes, and not to refer to every person in a larger body. And I think that we're learning more and more about the nuances and complexities of different bodies, diverse bodies, and when there is disease state and when there is not disease state. However, a lot of people who are in larger bodies have been assumed to have a lot of behaviors that may or may not be true. And I think it has made it hard for us to recognize and treat people with binge eating disorder with a lot of dignity. So we're working on it. Patients with binging and binge eating disorder have worse inflammatory markers, earlier onset of type 2 diabetes. Binging is very common in type 1 diabetes. Patients with binge eating disorder have worse sleep and worse sleep hygiene, worse sleep efficacy. And we've talked about circadian rhythm abnormalities, especially as it relates to night eating syndrome. So that is something that, again, this light therapy can be really helpful. I really love this Center for Environmental Therapeutics website, cet.org. You can take a quiz. You can take the quiz and find out when you should be using a light therapy box. What's the best for your circadian rhythm? So I recommend that to my patients very frequently. We talked about reproductive concerns as it relates to malnutrition and binging. And so here's this information that patients with binging and binge eating disorder are more likely to have PCOS, which can lead to difficulty with fertility. They're also more likely to have difficult pregnancies and fetal abnormalities. Patients with binge eating disorder who have had bariatric surgery are at high risk for complications, for having difficulty with their surgical site healing. If they are engaging in restrictive eating patterns, sometimes they can develop cross addiction, so they start to engage in compulsive use of other things like alcohol or other substances, which can become very dangerous when you have a shortcut through your gut. Alcohol gets absorbed very quickly in people who have binge eating disorder, or sorry, who have had bariatric surgery. And then we sometimes see really unique and interesting vitamin and mineral abnormalities because of the way that their bodies have been changed and how their eating patterns are changed. And so sometimes you see things, syndromes that you read about in textbooks, and it's a consequence of the bariatric surgery plus the abnormal eating behaviors. And then patients with eating disorders are at risk for misuse of prescription and other medications. So thyroid medications are misused by our patients. Stimulant medications may be misused. We want to be really careful about how we treat ADHD with stimulant medications in patients who have malnutrition. It doesn't mean never ever, but it's something we want to be careful about. We are starting to see more patients who are targeting the GLP-1 receptor agonist medications that are actually very much being targeted as weight loss medications. They're very expensive, but people are getting a hold of them. And we just don't know what that does to people who already have disordered eating vulnerabilities. Caffeine. So interestingly, people with eating disorders do not necessarily use more caffeine, but they use more in a discrete episode, which can cause cardiac complications and irritability. Nicotine is something that many of our patients struggle with. Substance use disorders are commonly co-occurring in people, especially with specific types of eating disorders, and have their own specific complications as it relates to the intersection of malnutrition and withdrawal. And so very often I recommend these people are at high levels of care so that we can keep an eye on things very closely, especially their cardiac functions. And then this just is sort of talking about, why we think nutrition is so important and why it can be difficult to get someone into a nutritive state, nourished state. There's the word I'm looking for, because sometimes it requires 5,000 to 6,000 calories a day to get renourished when you are underweight. People in early weight restoration are hypermetabolic, so their body needs a lot. And so working with a registered dietitian that knows about eating disorders, a therapist that knows about eating disorders, other eating disorder specialists or eating disorder informed people, I think is really key. Multidisciplinary care is the ideal. And this slide is here because I want to remind you that even though treating eating disorders is hard and sometimes feels overwhelming, it is so important because we know that most people who get treatment for their eating disorder recover. We have seen that even people who have severe and enduring eating disorders of 20+ years can get better. And we just don't know when the interventions are going to take hold and help them. And so we keep trying, and it can feel frustrating and it can feel like we're not making progress, and we do lose people, and it's very sad, but we do have to keep trying because we do know that if people keep coming back to treatment, the majority of them actually will eventually respond to treatment. And then I just want to give you some resources for where do I go from here? And I'm gonna stop with 1 minute, and I apologize that I didn't leave more time for questions, but I can stay on. So if you can, please feel free to join the discussion. Thank you so much for having me. It was a lot of information in a short period of time. I really appreciate the opportunity to share some stuff with you.
I'm going to start bringing in faculty members to join us on the panel, and please put questions in the Q&A and we'll draw from there as well.
I'll start. Oh, so go ahead.
Oh, I have a question.
Sure.
Hi. Did you mute that? Okay, thank you. My name is Eugenia Bricker. I run a consult service. And a lot of times I encounter patients that are severely malnourished, have severe anorexia, and at least on 2 instances, we've had to pursue involuntary treatment. So I was wondering if you could speak to kind of, I guess, tips to help with involuntary treatment, because there's a lot of emotions that come up from staff and everybody. So I was wondering if you had any advice about that.
Yeah, so that is a complicated issue. It's somewhat dependent state by state, and I will confess I do not know the laws in Kentucky very well or at all as it relates to how your probate courts are recognizing and defining grave disability. But there's sort of a divergence. So many states are recognizing eating disorders and inability to nourish oneself as a component of grave disability, and recognizing that as the need for ongoing involuntary intervention. In Colorado, we have actually been able to set statute to be able to treat people through weight restoration in an involuntary status, because we know that just because they might be like medically stable at the moment, their eating disorder is still very active. But there are other states like New Jersey where that's just not true right now. So somewhat dependent on states. And then in terms of just like managing staff experience with it. So my strong recommendation would be to see if there's any options to get someone to an eating disorder specific treatment center. It'd be that like acute at Denver Health if they're in that sort of medical state, or potentially seeing if you can get them to one of an inpatient facility or a somewhere in the country, whether that be Denver, Hopkins, or wherever it is that they can access and are willing to go, because likely if they are that sick, they're going to need ongoing involuntary interventions like tube feeds and restraints and things like that. And that becomes very taxing on the floor for the medical staff without any kind of behavioral components or the training that psych techs get and things like that. And then I would say that the majority of inpatient units, psychiatric units, are just not set up to be able to have somebody that has like a tube in, because that's a ligature risk. So it's a complicated balance. If you can't get them to another unit, they're there and you've got to deal with it, then I would say really helping to remind the staff why you're doing it. So even though this person may be very articulate, very intelligent, very able to think about all these things outside their eating disorder is a severe mental illness. It's very much compromising their ability to be in touch with reality, and just helping people to manage their own transference and countertransference as it relates to having to do this to this patient, I think is the best that we can do in those sorts of situations.
Dr. Davis, one thing has a question. He's very interested in this topic, I know.
Hey, Dr. Wassenaar. Thank you so much for that talk. I really appreciate all what you shared. I did have a quick question about just the role for psychiatry, especially with patients like Dr. Bricker was saying, who are severely malnourished with like a BMI of less than maybe 15. And I know you mentioned just how their ability to participate or be in touch with reality is severely inhibited. And I'm just wondering, as someone who's very interested in treating this population, what is our role in that circumstance? Is there a role for psychiatry? I know from a medicine standpoint, there's just not a whole lot of options we have, and not a whole lot of things that have good evidence. And I guess my question too is, when does that role take place? Since this sort of primarily behavioral, or the treatment is primarily behavioral. I mean, of course, nutrition first, kind of based off what you're saying, but I'm just wondering when that role takes place. And I guess, are we supposed to be leading in this multidisciplinary team? Is that what psychiatry does? Can you speak more to that? I'm sorry for all the questions, but
that's great. I love your enthusiasm. Yeah. So I really do think psychiatry has a critical role in being the team leader for this sort of situation, because we are the ones that are, hopefully, maybe if we're lucky, we got there before, we got to know them before they got super ill, and hopefully we're going to be able to be there after. So I think the things that we know are that treating eating disorders well requires the coordination of a multidisciplinary team. And I think psychiatrists are in a unique position to be able to coordinate with all of those professionals, dietitians, therapists, internal medicine people, other specialists. And then also we have the opportunity and really privilege, I think, of, you know, our field of practice is the balance of the relationship and the medicine. So we know that we have limited options in terms of medications that are going to necessarily like directly treat the eating disorder. However, we can very much think about how can we help them manage their distress and agitation safely. Are we thinking about things like Ativan versus Valium? Because, you know, we want to think about what's not going to build up in their system, what's not going to, you know, make them delirious. And then also thinking about antipsychotics, as I mentioned, can be very helpful for agitation. You know, sometimes people do hurt themselves when they're trying to avoid getting nutrition. And so we want to try to help them preserve their safety and dignity as best we can. And then the other thing I think that, you know, while they are oftentimes very delusional about the food and nutrition pieces, they're still, you know, their brains are still working around a lot of other things, especially as it relates to relationships, but their eating disorder has probably compromised their ability to accept and receive support. And so I think that our unique training of holding that therapeutic relationship and helping them to hold on to the hope that there is recovery, there is the opportunity for healthy relationships on the other side of this. And also I think that we serve a very crucial role to keep their family involved. You know, people with eating disorders do not recover in isolation, but their eating disorder wants nothing more for them to be in isolation. So our role of keeping them connected to the people that are important to them and remaining connected to us, I think, is really paramount. And it can be the thing that changes the experience of receiving treatment. Treatment is very, very difficult. It's painful. It's oftentimes involves, you know, things that they do not want to do. But to be able to do that with someone that you feel like is in your corner, that like knows you and likes you, that makes a huge difference. Sometimes that's the thing that brings them into treatment when everything else would keep them away. So yeah, I think there's a huge role. And I will say, you know, I don't know what all you offer at U of L in terms of eating disorder experiences and research, but if you're wanting to do a rotation on a eating disorder unit, we have opportunities in Denver, both in our acute unit at Denver Health and also at our behavioral health facility.
Thank you very much.
Dr. Ali Faruqi, one of our newer clinical faculty members, has a question.
Hey, thank you for the very comprehensive talk on the medical management. I actually have a three-part question. So the first was, I'm going to kind of piggyback on what Davis was saying, in that, you know, from what I found in the community, at least, psychologists and PsyDs tend to kind of hold this population pretty close. And I've kind of experienced a little bit of a restriction in terms of letting MDs in. I'm guessing it's because of a lack of medical treatment options outside of the acute malnutrition area. But that being said, my first question is, you know, this I feel like there's a lot of overlap in terms of the compulsive and impulsivity and the compulsive thought processes. What has been the role of treating this in a way similar to addiction with, say, naltrexone or Vivitrol injections? And my second question, kind of piggybacking off that too, is that in the world of addiction, I know Colleen Hanlon's done a lot of neuromodulatory work on breaking down thought processes, changing the neural circuits with emotions, et cetera, with neuromodulation and TMS. Is that where you see the field headed? Is there a drive in the field to head in that direction? Or is the drive pretty much to maintain status quo because of the parties involved in the treatment at present?
So for the first part of your question, naltrexone and Vivitrol. So we sometimes see some patients respond okay to naltrexone. I think it's probably similar to, I don't know if you've used naltrexone related to self-harm behaviors like compulsive self-harm behaviors. So it's something I'm more likely to try in somebody who has more of a bulimia nervosa picture versus an anorexia nervosa picture. And I can't explain the exact neuroscience of why it works in one population and not the other, but it doesn't seem to work well in people who compulsively restrict. So it seems to work better in people who are compulsively engaging in something versus compulsively restricting or inhibiting from something. But we do see it, and I would say it's very much worth a try. If someone's tried everything, you do want to start low and go slow because of the liver lab issue with naltrexone. So that's just a pearl. And then in terms of the future of the field, so I would say there is a lot of interest in doing better than we have done and not maintaining just the status quo. So in Denver, well, across our eating disorder at ERC, so we have locations in higher level of care locations in Baltimore and Chicago and Seattle and Denver and Texas. We do have TMS chairs, and we are looking at using TMS to try to treat both depression and OCD patterns in patients who have eating disorders. And we're also using a lot of ketamine. And we are finding ketamine to be incredibly impactful on the rigidity related to eating disorders. And, you know, like I mentioned, you know, depression and suicidality are an incredibly difficult comorbidity in patients with eating disorders. And in fact, acute suicidality can be the thing that prohibits them from getting eating disorder treatment, because if they can't keep themselves safe, then they can't be on an eating disorder unit. And so we very frequently are looking at ketamine as an option to help them treat that acute suicidality. And what we have found is that it really enhances their ability to stay safe on the unit, and oftentimes enhances their cognitive flexibility. And I'm really looking forward to the next phase of things. We'll see what gets approved in the next years, but I think that there are some interesting new things coming down the pike that can impact cognitive flexibility and impact, you know, new neural growth that are really going to open our field up.
Thank you for that response. A quick question about the neuromodulation. Do you guys do deep TMS or are you guys using a targeted TMS or with the SMA and frontal poles?
So we have a Mangaventure chair. So we do deep TMS if there's OCD patterns and we're working on ERP. We can also do like more of the SAINT trial if we're trying to treat severe depression. So we're able to be flexible with that. And I think that's probably the best thing that we can do, is to have the opportunity to be flexible, as flexible as we can.
And in terms of ketamine, or do you guys prefer IV or do you guys do intranasal? Because you mentioned acute suicidality,
So we are doing intranasal generic ketamine on site at our facilities. And in occasional patients, we are doing IM if we're having to go to a little bit higher dose. And we have some patients who are on Troches, I can never pronounce that word, in Texas, where that's what the law prefers. So that's another sort of interesting thing to learn about practicing in lots of different states.
You mentioned intranasal generics. You do racemic ketamine intranasal, not esketamine. Okay.
Do, yeah. And I have a lot of, I have, you know, I'm very interested in the ketamine work. And so I've done a lot of reading on the differences between racemic versus, you know, Spravato. And I like racemic ketamine for lots of reasons, but one of them is that we can be very, very specific in how we dose it. And so for our patients who are oftentimes medically compromised, we can be really tailored.
And just a follow-up question on that, do you dose with ideal body weight with the, because it's
No, we
pigs,
don't.
do
We
you do
dose
actual,
with the weight
right?
that they're at then.
That's
Yeah, yep, that's right. Yep. So that allows us to actually treat people who are underweight, pretty significantly underweight.
Thank you so much for answering all the questions.
Yeah.
Very good. We have a lot of interest in this subject. Apparently, Dr. Rabbani has a question. I'm going to ask her to ask it now.
Yes. First of all, thank you very much for this very interesting talk. And I was wondering if you can touch base on this, what we are hearing a lot, intermittent fasting. I am hearing some people 4 times a week they eat, and just one time, whatever they can eat a lot, but 4 times a week only. And some people once a while, 2-3 days or more days, they don't eat. What are the physical problems involved with that? And what is that? An eating disorder? Where is that?
Yeah. Yeah. So intermittent fasting is a difficult area because it's got a lot of proponents right now, and actually a lot of physicians do intermittent fasting. So it's an interesting area. So what I would say is that there's a lot of unanswered questions that we just don't know because we don't have any good long-term data yet, and I don't know if what we'll be able to get. We do know that if someone's brain experiences being malnourished for a period of time, it will go into that disordered pattern that I described with the Minnesota experiment. And that is just fact. So I think that every person has their own sort of like threshold of when their brain experiences malnutrition. And that's something that we don't have a really good way of judging right now. There's not a lot of external like ways to be able to sort of say like this is safe and this is not. I mean, it can happen like that. And once you sort of cross over into that malnourished state, if you have a vulnerable brain, and there's lots of ways that we're trying to gather data on which brains are more vulnerable, but we know that people who are highly perfectionistic and highly anxious and like that may have brains that are more vulnerable to malnutrition. And if you cross that threshold, then it is possible that you go into a disordered eating pattern and your brain gets stuck in that way of overvaluing your entire sort of being based on whether or not you're eating or not eating, or if you've lost weight and all of those sorts of things. The other thing I will say without any hesitation is I very, very, very strongly recommend against intermittent fasting for adolescents. I have had patients in my care who have been prescribed intermittent fasting at 13 and 14 years old. I think that is a huge mistake. We know that that the adolescent period is a very vulnerable state for the brain. And if they have a predisposition to disordered eating patterns and they engage in malnutrition patterns like that, the risk of developing an eating disorder is unfortunately quite high. And that could be part of what we're seeing right now. We're seeing just a tremendous increase in the number of eating disorders in adolescents. And, we know a lot of people tried lots of ways to be healthy 3 years ago when everyone started getting sick, including dieting and exercising. And there are a lot of vulnerable brains that are now bearing the consequence of that. So I don't recommend it. For me, for my patients, or for my friends and family. So that's a personal statement, but I will say that the data is still outstanding, but I am very hesitant.
Thank you very much. But physiologically, it is abnormal because, the day that they eat a lot, their physiology is different than the other day they don't eat at all. Then what happens? It is really electrolytes and hormones, everything. So it is something. I think they should write more about these things. That is not good. That of course their brain is not functioning that well, maybe, but they think it is okay. So
yeah, I agree. Yes, yeah. I will share my slides.
Thank you.
Yes.
Very much.
Thank you. Dr. Kostrowski, one of our fourth-year residents, has a question.
Hi, yes. So I was with a group of residents who initially connected with you at the APA. I believe it was during one of the palliative care lectures. I was wondering if you could comment on your experience. Have you had any experience with patients entering palliative care for kind of intractable anorexia or eating disorders? I know in Europe, I think that's a little bit more common practice. I know in the Netherlands, even there have been some patients who have undergone physician-assisted suicide and that kind of thing. I don't know if you have any experience in the palliative care realm for your patients.
So where I work now, I don't, because we don't do palliative care for eating disorders here. We treat eating disorders. But I have had patients who have left my care and worked with a palliative care team. And I've known patients who have died from their eating disorder and sort of a palliative care approach. This is a very complicated issue. So there's been a number of sort of recent developments in this particular field related to an article that came out just less than a year ago that referenced an approach called medical assistance in dying. And it was written by an eating disorder specialist internal medicine doctor here in Colorado. And there's been a couple written responses to that as well. So I think, the literature and discussion on this is ongoing. I would say that, so my perspective is that it's very much a balance of valuing the patient's autonomy and decision-making capacity and dignity, while we hold on to the idea that this is a treatable disease, and that we know that we know what the treatment is. The treatment is nutrition, and then we have to figure out why that's so hard. So I think that it's very, very complicated. It's very individualized. There is some emerging literature, so I'd encourage you to look into that. Patricia Westmoreland has written several opinion pieces on this particular subject. She's another eating disorder sort of expert in forensic psychiatry. And I think we're putting together some additional resources to maybe even present at APA next year. So hopefully I'll see you there again. That would be fantastic. And it's a complicated issue, but the bottom line is that this is a treatable disease. And so trying to figure out how we can value autonomy and dignity with a treatable disease is, I think, where we're at.
Thank you. Dr. Art Oliva, another one of our PGY4 residents, has a question.
Hi, Dr. Wassenaar. I was also one of the residents we met at APA. And I really appreciate you coming in and doing this talk. It's been very helpful from both a diagnostic and treatment perspective. So I was going to echo one of the questions Dr. Abbas, one of our third years, asked in the chat. I was kind of go off that a little bit. He was asking if you could briefly explain screening and preventative treatments you would do in the early stages of eating disorders. And I'd also follow up with that because I have a therapy patient right now who I think is developing an eating disorder. I wonder what therapy modality specifically you'd recommend from a psychotherapy perspective.
Yeah. So I think from a screening perspective, asking every patient you see in whatever context, and encouraging our colleagues to do the same, especially our primary care colleagues, asking questions like, what's your relationship like with food and your body? Are there ways you're trying to change your body, or and teasing apart, like, how much are they valuing their worth on their body size and shape? So starting there with gathering that information, and very often in psychiatry, when we start to express curiosity, it opens up, like, what are we supposed to do therapeutically, right? Because we ask the questions and then we figure out, like, where are the things. But from a big picture perspective, from a therapeutic approach, what I would recommend is doing a combination of motivational interviewing. So sort of helping them to recognize, like, what are they doing and how does it serve or not serve them? And then I also really like ACT-based therapy. So really looking at values-based intervention. So, like, what are their values? How are they moving towards them or away from them? And how are their behaviors serving them as it relates to their core values? And just sort of doing that. And there are some workbooks as well. So that may be a good resource to start, like ACT-based therapy for eating disorders and some things like that. Or you could just look at ACT-based therapies and then tie it into disordered eating patterns or disordered ways that they're experiencing their body size and shape.
Makes perfect sense. Thank you. Appreciate it.
Dr. Suleiman had a question as well. It's in the Q&A, but she's here on the line, so I don't know if she wants to ask it, but I'll just read it. She said, any different treatment strategies for a pregnant patient with eating disorder and who is afraid to gain weight?
Yeah, that's very, very complicated. So I would say that, because of that sort of special situation of wanting to help, well, I guess you have to start with the question about what their experience is like of being pregnant, and is this in line with what they are able to tolerate right now? Like, are they wanting to have this pregnancy come to term? So starting with just those big open-ended questions. But then if you have someone that is pregnant, they want to be pregnant, they want to deliver a healthy infant, then I would really have a pretty serious conversation with them about what they're able to do at what level of care. It could be that they need to be at a higher level of care to maintain their nutrition, so that they can get what their body needs in order to protect that pregnancy, and helping them to just really realistically look at where things are and how they're doing with that. This is assuming that they recognize they have an eating disorder and that they need help. If they don't recognize they have an eating disorder and they don't recognize they need help, then my best recommendation would be to start to pull in family resources and have those sort of like conversations around people are worried about this, people are worried about you. And again, getting back to what are your values here and how can we help you have the support you need to be able to achieve those.
Very good. Thank you. Being cognizant of our time, we have a few more moments. I have a couple questions in the queue. This may have already been addressed. Dr. Good asked, how can we support ED patients who are admitted to our inpatient psychiatric units for comorbid psychiatric problems?
Yeah, so what I would say there is, so if they're admitted to inpatient psych because of safety concerns, your priority is really the safety. So you're going to start with like, how can we address what's going on with them from the comorbidity perspective? What do they need in order to be stable enough to go back to eating disorder treatment? And hopefully that's the option, is that they're going between inpatient and eating disorder. And then the other option is they're admitted to inpatient psych, but they really need eating disorder treatment. So they're there, but they really need to be somewhere else. And that would be, I would say, helping them to, again, stay as safe and stable as they can, and helping them to get connected to going to a facility that can help them address the eating disorder more primarily.
Very good. And our final question, and my thanks as well. Dr. Abbas says, thank you for your presentation. Can you briefly speak to the screening and preventative and early stages of eating disorders and strategies for treatment in an outpatient setting?
Yeah. So again, I would say, starting with those big open-ended questions, if you are so compelled and it works with your workflow, I would say having some sort of screening questionnaires like the EDQ, the Eating Disorder Questionnaire, which is goes through all the disordered eating patterns, and then having people fill that out and having that be part of the routine, just like you would do a PHQ-9 or GAD-7 or something like that, so that it's just part of the data you're collecting over time, and then you have it, so you can start to notice if things change or don't change. So that would be, I think, probably the best strategy in an outpatient practice, to sort of just make it a part of your general screening. So, we are always sort of screening for new thought disorders or new, new safety concerns. We should also be screening for new disordered eating patterns or disordered experiences of one's body.
Very good. On that note, we can wrap up, and thank you for your time and your attention from the audience. And I guess they can reach you through an email information that'll be perhaps available in your slide set, and the slide set will be available as well.
Absolutely. And I will send those over to Christine so that she can get them available to you all. I thank you all very, very much for having me.
Thanks.